Hi, I'm Dr. Vibhu Viswanathan. I'm an orthopedic surgeon. I'm practicing at Ganga Hospital, Coimbatore, India. Um, this is going to be a few series of videos on the questions which have been asked in the PG entrance examinations in orthopedics and possible ways to handle and approach those questions. Everybody has gone through this period. Any practicing surgeon today has gone through this period. It's a very hard, tough time in life. One of my seniors used to say, he used to use the term information overload syndrome. With so much of information is packed into us during the short time, and it has to be reproduced in the right way at the right time. So definitely a lot of help from wherever it is required. It means a lot to us. I hope this current series of videos will. I think the purpose of these videos is to make you approach questions in such a way that you can produce answers. You definitely cannot know everything on the day of your examination, but with whatever knowledge you have, learn it the best way. Whenever you learn it, also you do it the way that you get the best yield out of those questions, out of the topics that you read. Every minute, every hour counts, so that you can give the best output on the day of the examination. So we'll start today with one of the common questions in pediatric orthopedics, which is asked. It's not just asked in your postgraduate entrance, it's also a question that keeps on getting repeated when you go into orthopedic residency. It's because it's such a common condition, and it is a very important condition. Every day, as if you are an orthopedic surgeon, pediatric orthopedic surgeon, you would be seeing one of these cases. So it's a supracondylar humerus fracture in children. So as I said just now, a lot of questions keep getting repeated on it, and we'll discuss which question paper has which topic at a later time. So supracondylar humerus fracture, it is it's the most common fracture around the elbow in children aged between 5 and 7 years. So it's the most common fracture around the elbow between 5 and 7 years of age. This is a question. If you see, there are types of supracondylar humerus fracture. What is the most common mechanism? Any fracture, see what is the age, whether there is anything common, and then what is the mechanism of injury. So there are, it's a fouge injury, most common is. It's a fall on outstretched hand. In one of your question papers, they have asked what is the most common fouge injury, fall on outstretched hand. So that answer for that question is distal radius. But supracondylar humerus fracture is also a fouge injury. Distal radius is also a common fracture in children. So you should keep these in mind. So what are the types of supracondylar humerus fracture? Generally, any fracture is classified based on the displacement of the distal fragment. So I have made a few pictures here. So the distal fragment, this is the distal fragment, this is the proximal fragment, this is medial lateral. Looking at it from the front, the distal fragment can move laterally, or the distal fragment can move medially on this. So again, on this one, this is the lateral plane. So this is anterior and this is posterior. Distal fragment can move backwards posteriorly, or the distal fragment can move forwards. So this is the first classification. First classification is whether the distal fragment is tilted and moved posteriorly. If this is so, then this looks like it is in extension. So there is extension at the fracture site. This is the most common type of injury, which is seen in 95 to 96% of these type of injuries. This you should be very careful. The rarer variety is the flexion type. Here the distal fragment is tilted as though you are flexing the elbow. So it's tilted like that, and that's why it's called the flexion type of injury, and it's tilted and it moves forward. So any classification in any fractures, if you go on, it is based on the displacement of the distal fragment. That you should understand. So extension type is the most common fracture. Okay, and among the extension type, there are two types. There is this distal fragment it moves laterally or it moves medially. So again, lateral is more common. Why lateral is more common? Because it's a force injury. When you do this, it possibly comes out this way. So understand things like this, then you don't have to by heart. So these are all MCQs. So extension injury is the most common, 95% to 96%, and then posterolateral is the most common among extension injuries. So the next question, why is this fracture so important? Because you should, whenever you see any patient, even in the emergency when you are a resident, whenever you see a patient with supracondylar injury, the first thing that you see is ask the patient to move the fingers, ask the patient to have a look at the capillary refill and palpate the pulses. So this is of extreme importance because neurovascular injuries are extremely common. Not extremely common, but they are known to happen with these injuries and they should not be missed. Can be devastating. So another question, next question that they ask is, what is the neurovascular injury? This is a common question. So again, you don't need to by heart. You can by heart, but you can always remember. If there's a confusion, you can. If you know the mechanism, then you can always go back and know about it. So extension injury, as we said, is the most common. So what happens whenever there is a neurovascular injury, in any fracture? You can always go to any fracture, approach any fracture this way. The proximal fragment, where there is a sharp piece of bone, so that is going to be where the nerve is irritated. So this is where the injury is going to be. So most common is an extension injury where the poking is anterior. So whenever you have the neurovascular injury, it is all anterior neurovascular structures. So brachial artery is the most common arterial injury. Okay. Next, what is the most common nerve injury? This is very commonly asked. Either you by heart or you learn it this way, so or do it both ways. So again, it should be some anterior structure. So the three nerves in the elbow, three main nerves in the elbow are median nerve, ulnar nerve, radial nerve. Okay. So the one thing that you should know is this distally, ulnar nerve is posterior and median and radial nerve are anterior. This is right at the level of the elbow. So they come anterior, both of these nerves. So in extension injury, it should be either the median nerve or the radial nerve. So remember it this way, because the poking is here, it is in the anterior structure, not in the posterior structure. So the first thing you can always remember very easily is, in a flexion injury, the most common nerve injury is ulnar nerve injury. Okay, because that is the only nerve which is posterior. Okay, done. And in extension injury, what is the more common nerve injury? Again, look at the two types. So this is the posterolateral type where the distal fragment is displaced laterally. This is the posteromedial type where the distal fragment is displaced medially. But as I said, the pinching of the nerve is not by the distal fragment. It's a small fragment. It won't pinch anything. But this is the major fragment. So in the posterolateral type of extension injury, the medial part of the bone is where the pinching of the nerve is. So what is here medially? This is the median nerve. Or more specifically, in supracondylar humerus fracture in children, because it is very, very distal, the injury is to the anterior interosseous branch of the median nerve. Okay, that is the most common injury. So you can by heart it. The most common nerve injury in supracondylar extension type fracture is anterior interosseous nerve first, next is median nerve, and the mechanism is what I described. The second most common nerve injury is the radial nerve, because again, if there is a posteromedial shift, the radial nerve is going to be anterolateral. So this part of the bone is going to be pressing on the nerve. So radial nerve is the third most common injury. The first most common nerve injury is anterior interosseous, second most common is median nerve, third most common is radial nerve, and the last common is ulnar nerve. So you should remember it. This is asked almost every paper. Okay. So first, as I said, the most common, whenever you talk about supracondylar humerus injury, you talk about all complications. So they have asked you all these complications. So which are the following? One of the question papers they have asked, which is the most common immediate, which of the following is not an immediate complication following supracondylar humerus fracture. So you should know what is the immediate complication of any fracture, early complication and late complication. This is how you classify. So immediate complication, that is when the patient presents, that's when you have it. Early complication is a few hours or a day or so. Late complication is much later than that. So again remember it. Immediate complications are arterial injury or one of the nerve injuries. Arterial injury is brachial artery injury. Nerve injuries anterior interosseous, more than median, more than radial, more than ulnar injury. Okay, so that's the immediate complication. You know it already well. Early complications, always early complications. Think of compartment syndrome, Volkmann's ischemia. So yeah, that develops as you see the patient in a few hours. The patient may not have much, you may have swelling, but as you see, keep seeing the patient in the ward, you will notice it. So remember it that way. Late complications. Any late complication in the supracondylar humerus fracture, the most common late complication you should never forget is cubitus varus. It's always asked. What is the most common late complication? Is the deformity. What is the problem with this fracture? This is a place of the bone which always unites. Irrespective of whatever you do, it's going to unite. So the problem is not union, the problem is malunion. Because when it is displaced like this, so as I said, this is the most common displacement, right? So when it's displaced like this, you start developing what is called as the gunstock deformity. Okay, this fragment is here. So you have a cubitus varus deformity. Cubitus varus deformity or gunstock deformity is the most common late complication. Other complications, just remember, Volkmann's ischemia can happen. So Volkmann's ischemic contracture. Other complication is myositis ossificans. Idhula one key point is gunstock deformity or cubitus varus deformity. Okay, yeah. So what is the osteotomy that is done for cubitus varus deformity? That is a question that has been asked. French osteotomy is used. It's just a wedge osteotomy to correct the deformity. That's all. Remember the name French osteotomy. There have been so many modifications of this. They can ask you step cut osteotomy. It can be a step cut osteotomy. It can be a dome osteotomy. So there are many modifications of this. But I think most probably so far from whatever questions they have asked, it's only a French osteotomy. And when do you need to do this surgery? You don't need to rush. There is nothing big that happens. Just the patient, one is cosmesis is better, and the other thing is it gives better strength to the arm. So, but usually any osteotomy that you do in a child, the bone keeps on growing. So sometimes it can become very unpredictable. Like you do any osteotomy, remember this point. In kids, whenever you do an osteotomy anywhere, if you do it at a very early age, the child has so much of power to do many things that sometimes as the child keeps going on, all the deformity it recurs. So don't do the deformity very early on. The injury happens at 5 years of age. It can wait until possibly maturity, if not that long, maybe as much as you can buy your time. So this has been asked again. So when do you do that surgery? Osteotomy close to maturity. That is all you need to know. Okay, whenever that's like something which always gets attached to this. Whenever you talk about supracondylar humerus, the next most common fracture in the small kid is a lateral condylar humerus fracture. Lateral condylar humerus fracture happens in a little younger patient. Okay, and it happens. It is the next common fracture in this age group. So it's usually like a varus stress injury where the lateral condyle of humerus avulses off. Okay, so again, the most important things that you always need to know in lateral condylar humerus fractures is it is prone to non-union. Unlike supracondylar humerus, it is a fracture that goes into non-union. So non-union, what is the problem? So there you have a cubitus varus. So what is a varus? Varus is whenever there is anything that goes closer to the midline, that is varus. The distal segment, so when you say varus of anything, the distal segment or that is the hand, when it comes closer to the midline of the body, it's a varus deformity. When it goes on the other side, that is a valgus deformity. I think you should all be knowing it well, but sometimes it confuses anybody. So in lateral condylar humerus, non-union is the most common complication. Cubitus valgus occurs as a result of this non-union. Okay, and another thing that you should also always remember is when it goes into valgus, there is a nerve which continues to get irritated over time. That is the nerve which is present here, which is that the ulnar nerve. So that is called a tardy ulnar nerve palsy. So these three are like high yield points. Always don't remember, they go together. I don't know whether it's been asked. I think it's been asked at some point. So lateral condylar humerus non-union leads to cubitus valgus, but it's not that cubitus varus deformity never happens. Okay, Sometimes it can go into malunion. Sometimes there are times when it looks like a pseudovarus. That is, this heals, but it heals with a lot of callus. So it looks as though the hand is in varus. Okay. So if at all there is a chance, there is a question which says, can this happen? Cubitus varus, it can happen. In fact, that is more common happening in a lateral condyle humerus malunion. But when it goes into non-union, it goes into valgus. Okay, that is what you should know.